everybody online. Right here. Hey guys, I got 9 o'clock. We're gonna head and get started. Couple things to communicate to you before we go. Working on, for all the medics out there, RSI, skills. We're working on that, the test outs, get a new test put together. That test will be made on a forms and you'll have a QR code to sign in to take that test. You'll take the test electronically before you show up, and then we'll set up the dates and we'll get Dr. Jackson and Zach and try to get that figured out as soon as we can. That's part of that. Don't forget EMS Skills Days at the last week of July into August 1st. Tuesday, Wednesday, Thursday, Friday. I believe that's what it is, 9 to noon. It'll be at the Rick Simulation Center. And if you need signatures or something like that, you need to get that stuff to me next week, because I'm going to be on vacation and be out after at about 2.5 hours. And I'm not that I'm counting or anything at all. So our first speaker is going to be Kate Sturrock. She's going to do our STEMI report, and I'm going to have her come up here.
If I haven't introduced myself, I'm the cardiac cath lab manager. I have a little bit of a quality background, and I did chest pain coordination at regional for a little bit. So I'm just kind of filling in interim until we get that chest pain coordinator position filled here at Union. So the first case I'm going to go through from Clinton, actually. And he was a 54-year-old male. He initially presented to Clinton ED on the 15th, around 9 a.m. I think he was driving to work, started having chest pain. He didn't have any relevant history. He was not a smoker. His first EKG was negative. Serial troponins were within normal limits, and EKG never really changed. So they were going to admit to cardiac unit here in Terre Haute, but we had a high demand for cardiac beds, of course. And so he actually stayed in the ER at Clinton all night. And so then they thought we can just discharge him home because there haven't been any changes. And they had a stress test scheduled for the following day. So he was discharged at around 10:30 on the 16th. Went home, started doing chores. 12:30, he called 911 for chest pain while he was feeding cattle. So when EMS arrived, he was ANO ×4, pink, warm, and dry, but he was really fidgety. When they got him into the ambulance, they tried to do a 12 lead, but that was hard because he was still fidgety. And I think he was kind of hairy too, so they were having trouble getting that EKG. They did see some VTAC, non-sustained VTAC on that 4 leads, and they did give lidocaine. They also gave aspirin and nitro. By the time they did get a 12 lead, it did show ST elevation in 1 and AVL, and these 1 through 4. ST depression in 3 and AVF. So they did notify Terre Haute via eBridge. They tried to do that. And then they also called ED for STEMI alert. So breakdown of the run history. You can see there, call to first medical contact was only 4 minutes, so that's great. First medical contact to EKG was 19 minutes, but that was, again, because of the fidgety and hairiness. Called in the STEMI alert at 12:57 and got to us at 1:21. Transport time was 39 minutes, and initial 911 call to arrival at Terre Haute was 51 minutes. And he got to Terre Haute, did an EKG here again, confirmed STEMI. Arrival to EKG there was 4 minutes, notified the physician and cath lab as soon as the patient arrived, and we were able to start the case in the cath lab at 1:40. So then they were able to balloon that opening at 2:01. So short balloon time for Union was 40 minutes, and EMS first medical contact to balloon was 87 minutes. So both of those were really great times. Here's the picture of the EKG that they got when he first got here. And then I tried something different. I'm going to try to play these videos. So this was the initial angiogram, and you expect to see two vessels coming off of this left vein, your LAD and your circumflex. What you're seeing here is actually a big diagonal branch off of the LAD. So it was kind of interesting that he has an anomalous circumflex takeoff that you can kind of see there. So I just wanted to call that out. That's kind of an interesting finding. So as soon as they got the wire across the lesion, we were able to get some of that slow flow going. Then once we got the stent in, we had the full perfusion there. So good case with good outcomes. He didn't have any other issues. He was able to be discharged on the 19th. So great job there with them. For Terre Haute, this is a patient that came in on May 10th. 60-year-old male. He initially called 911 with primary complaints of chest pain for 6 hours. He was a smoker, but no other relevant history. When EMS got to him, he was A&O times 4. He was sitting in a chair on the front porch, but he was pale and diaphoretic. When they got there, the patient did tell EMS that he had a cardiology appointment coming up, but he had not seen a cardiologist yet. He was able to self-transfer, answered questions, but then when he got on the cot, he became unresponsive, started CPR. They got him hooked up and saw his initial rhythm was VFib. So they did defibrillate with 200 joules. CPR, got ROSC after about 90 seconds. His level of consciousness was improving. He did go into a stable VTAC, and they did synchronize cardioverter him. He got back into sinus tach, and they eventually got to the ER here. EKG was done. Aspirin and nitro weren't administered because of nausea, vomiting, and the unstable blood pressure from the VTAC. So this was our EMS EKG. You see ST elevation in AVR, AVL, V1, V2, kind of diffuse anterior involvement. ST depression then in 2, 3, AVF, V5, V6. Again, looks the same when they got to Terre Haute. Run history, initial 911 call to first medical contact was 12 minutes. EMS EKG was done 9 minutes after arrival. Called the STEMI alert right away when they saw that 12 lead, and got to Terre Haute 9 minutes, within 9 minutes. So call to ER arrival was 30 minutes. Once he got to Terre Haute, did the EKG here again to confirm. 3 minutes from arrival to EKG, notified the physician in the cath lab at midnight 40. Got to cath lab at 1:15. It took 35 minutes from cath lab activation to patient arrival in cath lab. And then we were able to start the case at 1:30. Device activation at 1:48. So our door to balloon time was 72 minutes, and EMS first medical contact to balloon time was 90 minutes. So again, that is within our goals. So great job there. This patient was found to have a 100% left main stenosis. So this was really not what you want to see at 1:30 in the morning. So he, could have potentially been really bad. We were able to balloon that open, and you can just see that was just the balloon that gave us all of that perfusion. And then another picture of that, different angle, kind of shows where we were.
Oh.
After the stent placement, you can see how much of that myocardium was perfused with those vessels. So her cath lab, he was sent to ICU, worse, and they did put a balloon pump in cath lab just to kind of reduce some of that LV strain and treat cardiogenic shock. His echo later that day showed that he had an EF of 15 to 20%. He got to ICU. He was intubated in ICU for oxygenation. I have his blood gases up there because I have never seen a pH of 7.0. And if I did, the patient was actively dying. So I thought that was really relevant to call out as well, this really terrible ABG that he had. CO2 93, O2 is 53, and bicarb is 23.1. But he recovered. Balloon pump was removed on the 12th. He was extubated on the 15th, and he was discharged to a skilled nursing facility on the 20th with a life vest and guideline directed medical therapy to treat his low EF. So he may be a candidate for an ICD later, but not now. So highlights, again, all goal times were met. We had early pre-hospital notification, really great EMS documentation, and there were just a couple of things. The EMS EKG wasn't received in the ER until the patient arrived. And so if we had received that EKG a little sooner, we could have activated the cath lab before the patient got here, but that's always going to be an ongoing challenge there. So, great job.
Thanks, Kate. Anybody have any questions? Thank you very much. Next up is going to be Beth. She's going to be doing a stroke, I believe for both locations, right, Beth?
Yes.
Yep, she's going to be doing a stroke report for both locations. Thanks.
Good morning, everybody.
Morning.
I know I've been here with you a lot of times, but this is a little different role for me now. I continue to be the nurse care manager, or 2ESB, which is our ICU step down, where our stroke coordinator, where our stroke program's housed. But now that I'm also in the system stroke coordinator, I've taken over the Clinton program, and we're moving our stroke program more towards a system. It's more like we have with our chest pain is now a system-wide program. So please bear with me as I learn that program. It's very different at a critical access hospital versus here at Union. So I'm trying to learn that program and grow in that. So if you have any questions or anything about that, please reach out and I'll do my best to answer your questions as we grow this into one big happy program. Okay. Let's see here. You never want me to play with technology. This one's the first is a Terre Haute case. This was a 70-year-old male. He independently lived with his wife. He did have a previous CVA 2 years ago, and he did receive TPA at that time with no residual. He was from out of town, was here visiting. They went out to eat. And then his had symptom onset. He has a history of CAD, status post angioplasty, hyperlipidemia, hypertension, DVT and PEs, and he was currently on aspirin and Plavix. EMS was dispatched to a local restaurant. Upon arrival, they found the patient sitting in a chair at a table. He stated he had sudden onset of right eye peripheral disturbance and a severe headache. He was alert and orient times 3. His finger stick glucose was 130, GCS was 15, 3 lead EKGs showed sinus Brady, BP 77/80, pulse 53, respirators were good, SAT was good, and they did start an IV 20 gauge to his right AC. He was able to walk to the cart. The Cincinnati pre-hospital scale was negative, as was the VANS. And they did go ahead and call the stroke alert to Union with an ETA of 5 minutes. EMS response time, the patient's last known well was 15:40. Oh, that's not right. It was 12:45. EMS was notified at 12:57, dispatched at 12:59, en route at 1300, on scene at 13:07, and outpatient 13:08. The depart times were at 13:10. Stroke alert was called, did not have a time on the record, and they arrived at Union at 13:15. The patient went directly to CT. Last known was established with his wife, and she said the patient began to stare off and then suddenly had the sudden onset of visual disturbances and a headache occurred. Time he got to the Union ER, he had total vision loss in his right eye, so it was progressing. Before it was just a peripheral disturbance. Time he got here in that 8 minutes, he had totally lost vision. His NIH was 2. Stroke CT was done at 13:39 and it was negative for a bleed. Blood pressure remained okay at 178/87 and teleneuro was consulted. The decision was made to go ahead and give TNK in the presence of the low NIH due to the progression of his blindness. You know, usually when an NIH is that low, we do not give TNK. But, you know, the doctor always has that conversation with the patient that this is a deficit they can live with. You know, maybe if he just had tingling and numbness in his right hand at a 2, they probably would not have given it. But with progressive blindness in an otherwise reasonably healthy 71-year-old, they decided to go ahead and give it. And it was given at 14:11. Door yield time was 44 minutes because they had an issue with the teleneuro card. It kept dropping the call. So technology, it's great when it works. We know that. After the TNK was given, I did do a CT and it did show an occlusion of the right distal segment of the P2 segment of the PCA. I didn't make sense. I didn't type all the words in there. Maybe I was having a stroke when I did this. But he did have a distal occlusion of the distal P2 segment without any distal flow. So the PCA little artery in there, the posterior circulation of the brain, did have a total occlusion with that. The interventionist was consulted, but he was not a candidate for intervention for a lot of reasons. Usually when you have a posterior stroke, they don't do an intervention on them because actually a thrombectomy is not an approved treatment for a posterior stroke if it's in the basilar or the any of the arteries in the posterior circulation of the brain. You will have someone kind of do it off-label like you do some medications. But with the P2 segment of the PCA, it's a very small area to get into. It'd be very hard to feed a catheter there, so they could not do any kind of intervention with him. At the MRI was completed at 2009 and showed a large infarct involving the left PCA territory. So and the patient was admitted after that to the stroke unit. He did very well. The CT followed up, did show a mild hemorrhagic conversion after the TNK, and he was discharged home in 3 days. Due to his history of clotting, he had a history of DVT and PE. They did start him on Eliquis, and he lived out of the area, so all his referrals for follow-up were rehab back home in Richmond. But one thing about him, I did want to call your attention to. The great strengths of this case was the scales were completed. The stroke alert was called, and you recognize the signs of a posterior stroke. And posterior strokes are the biggest ones that we see missed, either by EMS and even in our ER, because the NIH, the VAN score are all biased towards anterior circulation strokes. Those anterior strokes are the ones we think fast, where they have the facial droop, the arm, the weakness. Those are anterior strokes. Those happen in your ACA, your MCA, that frontal circulation in your brain. The posterior circulation in your brain, if you think of the B fast, you hear that from the fast, the balance in the eyes, those are more posterior symptoms. Sometimes, you know, they think they come in and they can't sit up. You think, looks like they've been drinking, and they'll swear they haven't been, or surely they're on something. Those, you know, those when the drunk's not a drunk, it's probably a stroke, and those are often the ones we miss. And even his blindness was not a typical presentation of a stroke, because usually with a stroke, you get visual effects. They're usually part of each visual field of each eye, because the way the visual tracks cross in your brain, like you may have like the upper peripheral of both eyes. It's not often just one eye. And the teleneuro made a big comment in there about how the stroke symptoms were so atypical. So I think it's a very good thing that EMS recognized this as a stroke, because I think it would often have been missed. And I was really surprised that the patient called for having these symptoms. And I think if he had not had a previous stroke, received TPA in the past, and probably got some intensive stroke education, he would have missed it. And that MRI did reveal that he did have a very large stroke. But like I said, it's very hard to see those symptoms when all the testing we do is very biased against these type of strokes. So I think that was very good. The documentation on this was very good. So you guys did a great job. And some of the symptoms for a posterior stroke are just maybe memory loss, cognitive changes, headache, nausea, and sometimes just vomiting, and those balance disturbances. So it's always something to keep in the back of your mind that if you had those odd symptoms, that maybe it is a posterior stroke. This other one is a Clinton case. It was a 62-year-old female, lived independently with her family, had a history of CAD, status post-angioplasty, hyperlipidemia, hypertension, diabetes, and she was currently not on any blood thinners. EMS was dispatched to a private residence along with volunteer fire department because they said they had a patient down. Upon arrival, they found the patient sitting on a couch but being held up by two family members. They said she was up laughing and talking and suddenly had a sudden onset and fell over on the couch. She was unable to speak, totally flaccid on the right side with a right facial droop. Her last known will was established with family at 05:55. Her finger stick blood sugar was okay. Her GCS was 11. Cardiac monitor showed sinus rhythm. Blood pressure was 232/132. Pulse 90, respiratory 14. SAT was good. And they did start an IV and gave her some normal saline. Patient was able to be pivoted to the cart. The Cincinnati pre-hospital scale was positive. The VAN score was positive for aphasia and neglect. And a stroke alert was called to Clinton ER with an ETA of 4 to 5 minutes. Our EMS time was notified at 0600, dispatch was 0600, en route at 0602, on scene at 0607, and at patient at 0608. Depart time was 6:19, arrived at the ER at 23, and patient was transferred to their care at 06:25. In the ER, patient went directly from CT to EMS, to CT from EMS. Her NIH was 10. So we're getting to be a pretty significant stroke with an NIH of 10. Usually at that range, after a stroke, you're talking 10 to 12 patients probably going to end up at a SNF for a while for some rehab. So we're going to have, if we have a see an NIH that high, it's a significant disability. CT of the CT stroke was 0634. It was negative for bleed. Teleneuro was consulted and TNK was advised. At that time, her blood pressure was still 180/110, and one dose of labetalol was given. And then they were able to give the TNK, and it was administered at 35 minutes after arrival. It's 0703. CTA, they went ahead and did that, was completed 0734, and she did not have an LVO. So there's no mechanical treatment that we could do to fix that. She did have a 70% stenosis of her left ICA though. Patient was transferred to Union ICU via ground transport. Patient was admitted to our ICU. Her MRI was completed on 4/8. Showed multiple scattered acute infarcts of the left cerebral hemisphere. And usually when you have a multiple scattered infarcts, it's been a shower. It's a cardiac event. It's usually an embolic event, and you have just showered multiple little clots to one hemisphere of the brain. And the morning after receiving TNK, she reported numbness, but was able to ambulate 150 feet. So she went from being totally flaccid to being able to ambulate with assist, heavy assist, but she was able to do it 150 feet with a very unsteady gait. Her aphasia continued, but she ended up being discharged to our MRU. But I will tell you a little bit back history on this. I know it's not EMS, but it's kind of interesting. This patient was then transferred back to my unit, and we did an emergency carotid on her. That 70% stenosis group, when she was here in the hospital, they ended up doing an angiogram on her, and that was where her source was for her showering of the clots. So we did do a carotid on this hospital stay, and that's usually very unusual that you would do that. Usually when someone has a stroke or a lot of times a STEMI, you wait to do the open heart, you wait to do the carotid until they're a little bit more stable, have a little bit more time to heal. But we did do it emergently on her, and she did very well. She ended up being discharged home after that. The scales were completed, the alert was called, and I will tell you, there was great documentation. There was a great documentation on this case. When you read through it, it just really was logical. It showed you every step of the way through the patient, what they saw, what they found, what they did. It really walked you through it. So whoever documented that, great job. So thank you. It's really nice that we're seeing such great stroke care in our rural communities, because I can tell you when I took over stroke coordinator, a few years ago, we just weren't seeing that kind of great results in our rural communities, but we really are. And I will say that EMS has really elevated their game in these last years, and it's really been wonderful to see how much better stroke outcomes we're having in our community. And a lot of it starts with you guys. So thank you.
All right, I believe Tina's up next with trauma, but hey, I wanted to tell everybody, there is not a QR code at the end of this thing for you, so make sure you put in the chat your name and your PSID number, please, so I can add you to the list that shows you were on online. Appreciate it. Tina?
Morning. We have two cases this morning. The first one, I think these were both from April. This is a 39-year-old male laceration. 911 call came at 14:09. They were dispatched at 14:09, en route at 14:10, on scene at 14:12, 14:32, and at Union ER 14:38. So call dispatch was 0, dispatched en route was a minute, en route to arrival was 2. They were on scene to depart 20 minutes, depart to arrival, and ER was 16 minutes, so the total 911 call to arrival was 29 minutes. So this was, EMS was dispatched for a hemorrhage. On arrival, they found a patient standing on the front porch with law enforcement. Patient had been walking around and just punching in windows in this house. I don't believe it was his house. He has severe avulsion from his wrist to his elbow and his left arm. Appears to be cut down to the ligaments, and there was some bone exposed. Police applied a tourniquet at 14:10 just prior to arrival of EMS. Patient said he'd been drinking 1 pint of vodka that day. He said blood pressure 142/84, heart rate was 99, SAT was 95, GCS was 15. He was able to walk to the stretcher. They started an 18 gauge, gave him 100 of fentanyl, and gave him cefazolin, good for them. Pain was 9 out of 10 until they gave the pain medicine, and it was down to 4. They called an IHERN with a trauma alert and transported to Union ER. So they paged a level 2 trauma at 14:39. The IHERN with the trauma alert called. Pre-arrival, she said level 2, hang on to this, hemorrhagic bleed on the elbow, tourniquet applied. So the trauma activation level 2, page at 14:39, the ER physician was notified at 14:41. Patient said that he was punching windows because he had nothing better to do, and he wouldn't mind passing to his next slide, but this was not a suicide attempt, he said. He used meth 2 days before. So when I told you to hold on to your level 2, this is why. So if you look at this is our trauma activation criteria. It's based on physiological, like pulse, blood pressure, level of consciousness, and mechanism of injury. So if you see under level 1 where it says, I can't see that, active or uncontrolled hemorrhage, any source. So at the time he had uncontrolled bleeding. When he got to the ER, yes, it was controlled. because of the tourniquet. So they should have called this a level 1. So this was an under triage. But great for EMS given the antibiotics, and great for the police officer. And I'll get to that in a second. So he arrived 1447. Vitals were temp was 36.9, pulse was 90, rest 20, blood pressure 127/88, 94% on Rivera. He has a history of schizophrenia. So the tourniquet was in place on his left upper extremity. There was below that was an 8 centimeter gapping laceration with exposure vascular that tracked down to bone. So the patient had decreased sensation in all of his digits in the left hand. The tourniquet was released at 1444, had increased capillary refill, of course. Patient reports improved sensation in the hand, no pulsable blood, and general oozing was demonstrated. So they put a pressure dressing on, they talked to trauma and ortho. Patient went right to OR and was to be admitted to trauma. Orthopedics took him to surgery. So he had imaging of his x-ray of the left hand, left radius and ulna. There was some soft tissue swelling around the forearm and elbow. Labs, he had the drug screen. He was positive for benzos, pot and opiates. He was negative alcohol. Diagnosis, laceration to the forearm. He went to the OR for repair of the laceration, debridement, and drain placement. Said continue antibiotics, elevate the arm. He ended up being admitted to the hospital with ortho and trauma consults. Day 2, there was a psych consult. They said they recommended inpatient psych placement, so they were working on that. Day 2, trauma came and saw him and said there wasn't anything for them to do. They signed off. And then day 3, vitals were stable, pain was controlled. He was accepted to an inpatient psych facility up in Indianapolis. Follow up with ortho. DC instructions were sent with the patient. Follow up with ortho 3 weeks, and the dressing and the Penrose was to come out in 2 days. And that's kind of it with him. It was just kind of a neat story because the law enforcement, and we did find out who the officer was and sent a letter to them to acknowledge what he had done and to thank him. So, anything? No? Well, great job by EMS to give the antibiotics. Great job by the police department acknowledging that that was a severe hemorrhage and putting the tourniquet on. As far as the ER, we could have done a little better, acknowledging that that was a level 1 trauma. But that was followed up on, and we gave education to the physicians and to the nurses about that. We do that constantly. He got all the care he received, and that had a good outcome. So, anything? So the second case, this was a 20-year-old male. This was an MBA. 911 call at 6:48, dispatched at 6:48, en route 6:49. On scene at 06:55, depart at 7:18, and at Union ER at 7:30. Times called dispatch was 0, dispatched en route was 1 minute, en route to arrival was 6 minutes. On scene to departure was 23 minutes, departure to arrival in ER was 17 minutes, and call to arrival was 47 minutes total. So this was, the EMS was dispatched for a 20-year-old male as an MBA. On arrival, there were 2 cars. One of them had minor front end damage. The other was a 4-door sedan front end, with airbag deployment. And that car was the EMS run patient. So the patient was traveling about 45 miles an hour on impact. Patient was found in the front passenger seat, and they noticed there was blood on the front of his pant leg. There was an obvious deformity and a wound to the left femur just above the knee. So bleeding was controlled with a pressure dressing. They started an IV in his right AC, gave him ketamine before they moved him. He was a bigger guy and it was a smaller car, so they were gonna have to maneuver him a little bit. They secured his left leg while moving him. They started a second IV. Patient was screaming in pain. They gave him second ketamine, which seemed to help. They gave him cefazolin en route. Wasn't a time documented. I heard what trauma alert was called and he was transported to Union ER. So this was called level 1 by Dr. Jackson. Level 1 trauma activation at 7:32. Trauma surgeon was present at 7:35. The patient arrived in the ER at 7:34. The vitals temp was 37, pulse 85, rest 11. His blood pressure was 163/105, 99% on Remair. So this says restrained driver, so I'm not sure, I think he was the passenger. And the MVA is 45 miles an hour, airbag deployment. He had an open fracture of the left femur. He had severe pain, laceration on the lateral portion, the mid shaft of the femur. Bleeding was controlled. Deformity to the left thigh with the 4 centimeter laceration, lateral portion, mid distal thigh. Some oozing, no arterial hemorrhage. Easily controlled with pressure dressing, swelling and tenderness in the lateral portion of the left foot. Limited range of motion due to the femur pain. They did a fast and it was negative. Ortho consult was done in ER. They gave him IV fentanyl. Cefazolin 1 gram. This is from the ER now. Given via EMS and was verified by the provider. I do remember Dr. Jackson talking to them because there wasn't a time documented. So he did call and talk to them to verify that. So this is, again, the activation criteria. An open fracture is a level 2, but because there was a question of how severe the hemorrhage was, I think is why he called it a level 1, which is appropriate. Labs, white count was 10.4, hemoglobin 13.6, sodium 132, and his glucose was 248. Imaging, he had an x-ray of the pelvis and the left femur. Comminuted fracture displaced the left femur. The head, CT of the spine, chest x-ray were all negative for trauma injury. X-ray of the left foot, he had a comminuted fracture of the left femur. They saw that from the foot. So his diagnosis was open displaced oblique fracture of the shaft of the left femur. He was admitted to trauma with ortho consult. He went to OR for irrigation debridement for the open fracture of the left femur. And they did some nailing. It was a grade 2 open distal fracture. It was a pretty nasty fracture. I'll show you here in a second. So they continued the IV antibiotics for 24 hours, gave him Lovenox the next morning, ordered meds for pain control, PT, saw him the next day. His leg was wrapped. Pain was well controlled, vitals were stable. PT and OT recommended discharge home. They got him up and walked him with crutches. You can do toe touch with weight bearing or toe touch weight bearing, sorry, and discharged home the next day. Follow up with ortho in 2 weeks. So this is a fracture. I know. It just makes your stomach knot. I was like, damn. He was awake and talking to us, actually kind of joking around a little bit. I don't think he was at first, but I think by the time he got here, the ketamine kicked in. What happened was he was like I said, he was a little bit of a bigger guy. It was a smaller sedan. So I think he saw it coming and he put his foot up like that. Snap. Yeah, what was the left leg, but he just like, oh, gee, and it just snapped his leg. So don't do that. So yeah, it was a nasty, nasty fracture. And he went home the next day. So he went and saw the doctor 3 weeks later. And this was the x-rays, the post-op x-rays they took. And the only question I had, and I mean, I guess I don't know anything about ortho, but that looked kind of like it was, I don't know if it's the angle of the bone, that looks maybe more like it was a lateral picture, I don't know. That was the only thing that looked kind of weird to me. I'm guessing it fills in, I don't know.
You will.
It will,
You're possible.
yeah. I'm like, that's a big old rod in his legs.
Yep.
But anyhow, he
It's a big
did
bone.
great, and the doctor was happy with him from the office notes that I saw a few weeks later, and so, great job by EMS to give him, the antibiotics and, guy right to surgery and he did really well.
I like the pain medicine before they move him. That's one of my stuff. After looking at the x-ray, like, oh, I really appreciated that bunch, so. All right, guys, next up, we've got a presentation by Nick Miller. He'll describe everything to you, what he's gonna talk about, so.
Yeah. Does the clicker work?
It might. Try it, see. There you go.
Back in February, we had a pretty good wreck out at 42 and 46. The trauma department here at Union already did a case study on the patients. They did a pretty good job. If you remember, pretty much everything below the waist for the two patients that arrived here at Union was broken. We will go a little bit over that, but mostly this presentation is going to be about what happened operationally and how we can tie it into MCIs and our STAR triage system that we use here in Vigo County. Before I started, I want to have a disclaimer. Whenever you talk about MCIs, whenever you talk about triage, we can get a little callous, especially when we start talking about things like black tags. But understand, it's not callousness, it's not insensitivity, it's just a realistic idea of what we need to do on scene with the resources available. Also understand that lives were changed with this run, some permanently, some for the rest of their lives. It was a pretty major incident. First though, I want to talk about a mass casualty incident and its definition, or an MCI. We know whenever we teach mass casualty incidents to basic students or EMR students, that the definition is a greater number of patients than resources available. However, what if some of those patients are at different levels of triage? What if some are stable, or what if some are unstable? And then what if those resources are not available right now, but they're going to be available in 2 minutes, 5 minutes, 10 minutes, 15 minutes? Start thinking about that as we go through these patients in this scenario. Oh.
That's kind of.
In Vigo County, whenever we have an MCI, we use the STAR triage system. We have 4 different tags.
About people with ADHD and caffeine.
How it does the opposite effect?
Hey,
Yeah.
mute your phone.
When we have MCIs, we use the STAR triage system here in Vigo County. We have 4 different tags. Green tag is a minor patient. We call those the walking wounded. They can care for themselves. They're not likely to deteriorate here in the next couple of days with their injury. They're the kind of patients that you see on scene and you ask them if there's anything going on with them. They say, my ankle hurts. You say, all right, go over there to that tent right there. We don't want to talk to you. Yellow stands for delayed. These are patients that we recognize have serious and potential life-threatening injuries that are unlikely to deteriorate significantly over the next several hours. These are patients that we recognize absolutely could have something going on with them, but due to their current presentation, we don't think they're going to be deteriorating, so we're going to put them over here. Red is immediate, stands for patients in need of immediate treatment and transport. They have compromises to their airway, their breathing, and their circulation. We look at these patients and we know that time is a factor for them. They know they need immediate interventions. And then black is expectant, which means unlikely to survive the availability of care, injuries, or a combination of the two. What's important about a black tag in the word expectant is that it doesn't necessarily mean dead right there, DRT, right? It means very possibly could become DRT right in front of us. Expectant, they could possibly pass, they're most likely to pass away and become deceased in the next couple minutes and the next couple of areas. All right. Think about the STAR triage system as we talk about our patients as well. So the accident occurred at approximately 12:50. We know post-incident that 2 vehicles collided at the intersection of 42 and 46 at high rate of speed and then struck another stopped vehicle. Overall, 911 dispatch got 6 notifications. 4 were direct phone calls, 1 was an OnStar notification, and the other was an iPhone notification. The OnStar notification was very short. It said something along the lines of the owner of this vehicle stopped suddenly, had a change of direction of about 21 miles per hour. They could be in a wreck. The iPhone notification was something along the lines of the owner of this iPhone has had a sudden stop of acceleration. They could have been in a wreck. The 4 direct phone calls can be summed up like this. 3-car accident. 1 car got thrown really hard. They're still on the side of the road. No, everybody's still in their vehicle. There's a maroon truck, a black hatchback, and a smaller white SUV. I don't know, they're all in several different directions. There was an awful crash. Sorry, I'm panicking a bit. Here, talk to my friends.
Yeah.
2 cars are completely totaled, all 3 cars went completely flying. I like this one. I can give you license plate numbers when you're ready. Absolutely flying, there was a serious accident. Overall, dispatchers took a total of 214 seconds talking to
Security alert,
individuals on the phone.
behavioral response, 3101. Security alert, behavioral response, 3101. Security alert, behavioral response, 3101.
Is 214 seconds with the information that we saw here enough to really get a good picture of what happened? No, not really, right? And I'll be the first to tell you, I've been somebody traveling down the road, being dispatched to run and pounding on the dashboard saying, those dispatchers are idiots, they don't know nothing. But when they get information like this and they only be able to talk for 214 seconds, it's kind of hard to get a full picture of what really is going to be needed for this kind of ride. So because 911 dispatch didn't really know what to do, I mean, they knew what to do, but they didn't know exactly how many resources were needed, they just went ahead and dispatched ladder rate for an MVA with unknown injuries. Ladder rate was dispatched at 12:54, they're around 12:56. Because we live in the city of Terre Haute, shocker, no city ambulances were available. So transfer was dispatched initially, medic 9 who's hanging out at Union disregards him and then takes the run. An exact quote from a ladder rate crew member was about 30 seconds before getting there, state police arrived, stated they had multiple patients entrapped, 1 patient possibly critical. So then, dispatch upgraded. MVA with entrapment, dispatch at 12:58. For us here at the city of Terre Haute, that means we get our battalion vehicle, battalion 2. For incident command, we got our support vehicle, support 5, which has a lot of extrication equipment on it, an additional engine, or an additional fire apparatus, in this case it was engine 11, and then we get another ambulance. And of course, because we live in the city of Terre Haute, no city ambulances were available, so TransCare was initially dispatched. However, Medic 8 was also at Union completing, so they went ahead and disregarded TransCare. But dispatch went ahead and let them know that we've had multiple calls on this, so not a bad idea to have TransCare continue, so they do. Ladder rate arrives at 1300. Their scene size up is roughly a 3-car MVA. Heavy damage to all vehicles, 2 on one side, 1 on the roadway. Ladder 8 at the time has 4 crew members. It is a BLS apparatus. Because there's only 4 crew members and possibly 4 patients, start triage system begins. In truck 1, we find a male patient sitting in the driver's seat, alert oriented ×3 with a chief complaint of leg pain. In car 1, which is a gray SUV, we have a male patient, alert oriented ×3 in the driver's seat with a chief complaint of back pain. And then in car 2, which is a white SUV, we have a male passenger, alert oriented ×3 with a CC of leg pain, and a female patient who is unconscious that is tangled up with the passenger. She is unconscious, breathing slowly, and according to ladder rate personnel, has a rapid carotid pulse. Any guesses on the patients of their triage status? I'm gonna guess yellow, 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 and red. We know those patients, we know the truck guy, the gray SUV guy, and the male passenger. We know they potentially could have some serious injuries, but at this time, we don't think they're gonna be deteriorating in the next couple hours, so we're gonna go ahead and give them a yellow tag. And then we have a patient, a female patient who's unconscious, breathing slowly and a rapid carotid pulse. I would say breathing slowly and the rapid carotid pulse would be a problem with her ABCs. I would call her a red tag. These vehicles were all mangled, so we needed to also do an extrication triage and recognize what kind of resources are going to be needed at each vehicle. For truck 1, it had heavy front end damage, and we recognized that extrication would be needed to get the patient out. In car 1, the gray SUV, we recognized that there was moderate damage all over and the driver's door was going to need extrication. And in car 2, with the 2 patients, heavy damage to the front end and sides, extrication needed for removal. Whenever they teach extrication, even when a car is slightly mangled and we're using our extrication equipment, we recognize and we know how the metal is going to move whenever we apply our cutters and our spreaders. In this case, car 2 was so heavily mangled, it was like a piece of metal tissue paper. So every time we tried to jam a piece of equipment into it and we wanted it to move a certain way, it wouldn't move in any direction that we wanted it to. So it took significant time to extricate all the patients in car 2. Car 4, that's me, self-dispatches themselves at 13:04. I just arrived at lunch. I got back to the training center. I saw Floyd Mason sitting in his office, and he had a real serious look on his face. And if you guys know Floyd Mason, he doesn't have serious going on in his body. So I was like, what are you doing? He's like, oh, ladder H arrived on scene and it sounds pretty serious. I was like, well, I got a car, I'm gonna go out there then. So I self-dispatched myself. Ladder 8 recognizes with the triage system that we have a red patient in car 2, so that's where we're gonna begin our extrication. They do a door pop on the patient, which takes about 4 minutes, and then ladder 8 personnel and a state trooper perform an emergent move on the female patient. If we remember, we're back in our basic EMT, an emergent move is a quick move that does not recognize C-spine. It's a move that we know that that patient has life or limb-threatening illnesses or injuries, and that we need to get that patient out of there. So they snatch her out. Upon snatching her out, they find the patient to be pulseless and apneic. That patient that was a red tag just went to a black tag. What do we do when the red tag becomes a black tag? We just get up off our knees, wipe our hands off, and say, well, that one's done. Throw a sheet over them.
Open the airway, see if they can get anything going.
Open the airway, yep, and they're still happening. What do we do whenever the black or the red tag turns into a black tag, but we know that we have resources on the way? What do we do when the red tag turns into a black tag, but we know that the current patients are inaccessible due to extrication? We start doing CPR. I think it was perfectly appropriate to black tag that patient, move on to the other ones, but I also think as well that it's perfectly appropriate to start CPR. When we arrived on scene, we saw that that patient did have a pulse, did have a chance. I think there's nothing wrong with doing what we can do to see if we can give her a chance. Battalion 2 heard this while en route, so they requested another engine for manpower and had them dispatched out. Then the cavalry arrives. Engine 11 arrives at 1306. That's a paramedic engine. There's 3 paramedics on it. The officer goes to goes to car 2 and starts helping with extrication. The backstepper starts helping out with CPR, and then the driver of engine 11 pulls off the line, puts the trunk in a pump gear, and starts getting the line ready just in case something were to catch on fire. Medic 8 arrives and they start to continue triage and reassess the patients that are still entrapped. Medic 9 arrives. They immediately go to the CPR patient. Engine 3 is dispatched at 1307. Battalion 2 requests another ambulance. Transcare marks en route at 1307. Support arrives. Support 5 arrives at 1307. 2 paramedics as well. They take over incident command, and Battalion 2 arrives at 1308. They take over command from Support 5. Support 5 then goes and starts doing a door pop on one of the other vehicles. I arrive at 1310. When I arrived, I pulled off to the side. I saw that they were moving the cot up with the patient doing CPR, so I was like, that's where I'm going. I hopped in the back of Medic 9. The lights shone down on the patient that we were doing CPR on, and you can ask the guys over there. I immediately go, oh, guys. This patient didn't have a good chance. That patient was unresponsive, pulseless and apneic, cool, pale, dry skin, obvious bilateral lower extremity fractures, obvious right humerus fracture, obvious left wrist fracture, dry blood on right side of the head, unknown if the blood came from the patient or the other member of the vehicle. Patient had really thick hair. Right after we started ACLS protocols on that patient, I went ahead and whipped out my phone. I called Union. I got the secretary. I said, I need the charge nurse. We got a pretty good run out here. I think I got Emily Wozniak. She was like, I'm not charged today, but what's going on? And I was like, we got a good wreck coming in. We got a traumatic wreck coming in. There's at least 3 people entrapped. We're going to need all hands on deck for this. I know Chief Luther called Barry direct and said, hey, Barry, we got a pretty good wreck out at 42 and 46. Probably not an idea for you to get up there and start getting things ready. Pre-hospital notifications are important. We have to let the hospital know what's going on scene and what we're coming in bringing with. They can't do anything if they don't know. And it doesn't even matter if this was, or it doesn't matter if it's just a trauma. If it's a STEMI or a stroke, they have to know ahead of time. Please let the hospital know earlier. Medic 8 climbed in the back of the vehicle and started treatment on the male patient. They started an IV, they gave fentanyl, they started giving more normal saline. They had manual C-spine held and they did a C-collar. I'm all about, just like Barry actually just said 15 minutes ago, I'm all about climbing into that vehicle, start treatment early with that patient, give him some IV fentanyl. I think remember that everything was broken from the top down. They probably earned it a little bit. Engine 3 arrives, does a door pop on the final patient, and then starts helping out with extrication. Transcare medics 142 and 136 arrive. They both take the truck and the other car patient. They get the patient extricated, Medicaid transport emergence at 1331. Their patient had in the right leg, they had an upper deformity, lower leg deformity, an ankle deformity, and the left leg, lower leg deformity, and ankle deformity. Here's his vitals. The only thing I can really point out is that from 1320 to 1335, only had one set of vitals. Not a big fan of that. These are obviously critical patients. We should really be trying to do it every 5 minutes, but we're never going back and forth, trying to get bilateral IVs, things like that. I understand it happens. So there's a respiratory rate there at 39. That's probably not true at all. That's probably just the monitor acting a fool. Overall, they had about a 20 to 25 minute extrication time. They had full spinal mobilization. They did another IV and they gave that patient more fentanyl. Yeah, I think you earned it. Transcare medic 136 transports the car 1 patient. That patient had a complaint of some lower back pain. Initially refused treatment, but then decided he wanted to go to the hospital. He didn't have any deformities or reported abnormalities. He refused to C-collar. He was able to stand and pivot. Unsuccessful IV attempt. He went to regional hospital. If I recall, I think he was discharged directly from the ER with no major complaints or abnormalities. Transcare medic 142 transported the truck 1 patient at 1335 emergent. What I think is really great is that they gave IM fentanyl while the patient was sitting in the vehicle. Not all of us like to climb into mangled vehicles and try to do what we can to treat patients. We know that our pain meds have other routes. She used IM fentanyl. I think that's awesome. Bilateral IVs, I got normal saline, they got some more fentanyl, they also got an antibiotic. For this patient, when the patient's clothes were cut away, assessments revealed pain in both femurs, indicating probable fractures. We know that was true. Open bilateral tib fib fractures, left knee open fracture, and deformity to the right ankle. Here's its vitals. Again, we had a little bit of a gap, a 12-minute gap. I kind of wish that was shorter. I wish in general we had 5-minute vitals, but 4-minute vitals from 42 and 46 to, or 4 vitals from 42 and 46 to Union, I still think is pretty solid. The question was asked, should we have flown any of these patients? Post-incident, we know both these patients did end up going to Indianapolis. So truthfully, yeah, we probably would have liked to fly. There were some miscommunication errors with Lifeline on whether or not they could fly, but overall, I don't think they could fly Kilo weather. Something I'm a big fan of living here in the city of Terre Haute is that we actually don't land helicopters in the city. We operated back the ambulance as our office space, so it's perfectly reasonable for us to put that patient in the back of our ambulance, take them to the airfield and fly them out from there. We should not be landing, unless we have prolonged extrication times, we should not be landing helicopters in the city. We should take them out to them. And the county, it's a different story. At the beginning of the presentation, I said that MCIs are very simply taught, but if this is any indicator, it shows that they are not simple instances at all. They are everything but simple. We need a good incident command. We need to keep our heads on a swivel. We need to recognize that things are going to rapidly change at all times. I think it's probably a good idea for us to start doing some more trainings, inter-agency and inter-facility wise, so we can get ready for these kinds of incidences. If that car 2 that had the 2 patients in it, what if they were transporting 3 of their grandkids at the time? What if truck 1 was transporting somebody in their passenger seat? What if that car had 4 other people in it? It could have gotten real ugly real fast. So let's recognize that MCIs are something we may not necessarily be prepared for, but we're pretty good at shooting from the hip. So let's do some more drinking. Thank you.
Thanks, Nick. That's great. All right, guys. Next up is Amy Purdy. She's going to do our educational talk today.
All right, I'm Amy Purdy. I'm a registered nurse here at the NICU at the hospital. I'm gonna talk about newborn stabilization. I know you guys hate baby things that come with that, but in the last 2 months, we've actually had 2 babies born at home, and EMS has brought those babies into us. So thought we'd kind of do an overview of things for you guys. Probably the main thing is temp regulation. Both those babies that came in would not even register on a thermometer because they were so cold. They both were born in the toilet. So yes, they did have water immersion, so they were a little bit colder, but just some things to help trigger you guys when you're in that situation, what we can do to try to keep them warm and things like that. So we're gonna go over just an introduction, I introduce myself, what we're gonna talk about. Some questions that you guys can ask yourself when you're en route to a situation like this, maybe when you get the call. What to expect when you guys arrive, some basic newborn stabilization things, and then how to transport the newborn to the hospital. So what are some questions you guys can think of that you might want to ask en route? Maybe some history on mom, about her current pregnancy. What are some things that you guys start to think of if you get a call about someone who you think is going to be delivering at home?
Kids,
How many kids? Yeah,
pregnancies, issues,
because that tells you what.
that's a good job.
Right, exactly. Right, yeah. If it's her third, fourth, fifth baby, it's not gonna probably take very long. She's probably going to deliver pretty quickly. Yep.
Prenatal care.
Prenatal care, that's a big one. Yep.
Your water broke, guys.
Have your water broke. Yep, what color is the water? Because that's a big one. If the water is clear or if there's any discoloration, can tell you there's been some stress. Yep.
Gestational age.
Gestational age. Yep. A big one here lately has been drugs. These moms do not want to come into the hospital. They wait as long as possible to be able to deliver. And then once it's too far along, they can't go back. So a lot of times when you get on the scene, they probably have been doing drugs. So a good question to ask is look around the environment. What's the house look like? Where are they at? We had one that they brought in here that the mom actually was transported from one house to another while she was in labor. So that was a little fishy. Why are you moving a pregnant woman from one house to another? And it ended up being meth. So some things to think about. So like you guys said, how far along is the mom in her pregnancy? The last one we got actually was a 32-weeker. So that baby was a little bit earlier. So it's going to be a smaller baby. So, you know, temp regulation, blood sugar, things like that are going to be really important with those little babies. Like you said, did she receive prenatal care? Has anybody seen her? If she's not had prenatal care, that baby can actually have things wrong with it that you're not even going to know about. So see if she knows if she's had any kind of ultrasound or anything like that. When did her symptoms start? When has her water broken? Those are all important things. Sometimes these ladies will be in labor and their water may have been broke for a day, 24 hours, 48 hours, those kind of things put the baby at risk of infection. So those are important for us to know when you guys get there. What color is the amniotic fluid if she is ruptured? How many pregnancies is this for her? Like we talked about, the more they have, the faster they come. Any history of drugs? They may be forthcoming and tell you they did drugs, or more than likely they may not tell you that either. And then you want to make sure you guys have all the supplies you need to do a birth. You guys have a baby pack, right, on your rig when you guys go? So is it time? There's that sweet little clean baby. So what do you guys need when you arrive? Of course, oxygen. You guys have like a mask, right? Like blow by or a mask or something of that nature. You got your baby pack, which will hopefully include a bulb syringe to be able to suction their mouth and nose, gloves, a hat, a diaper, a baby blanket, a cord clamp, because you're going to have to clamp the cord between the placenta and the baby, and scissors. Try to use clean scissors, you know, to be able to cut the cord. And then you want to be able to transport the placenta. So a bag and container, something of that nature to bring the placenta with you. Another thing is too, the big thing for the placenta and the cord is that they can do drug testing off the cord. So try to bring everything you can with you. Also, if you think there's any history of drugs, or even if you don't know, you can put cotton balls or a liner in the baby's diaper. And then when they get here, we can actually squeeze the urine out of that to be able to send a lab for confirmation if there's drugs in the baby's system. So what are you going to do if this baby's going to be born? If you can see the presenting part, hopefully it's a head. Sometimes it can be a foot or a butt. And if the mom's unable to wait, you want to put on your gloves, help the mom deliver. Before the baby's head is born, if you have time, you want to try to suction out their mouth and nose, because the first breath they're going to take, they're going to suck in whatever they can right there. Any amniotic fluid, if it's discolored in stool, whatever it is going to go straight down to their lungs. If the baby is crying and has good tone, place the babe on the mom. Skin to skin is the best way to keep them warm. You want to dry stimulate them while waiting on the mom to deliver the placenta. After the placenta is delivered, you want to clamp the cord. You want to do it about 3 to 4 inches above their umbilicus. Give us a little bit of room, because actually if it's a baby that's born out of root, we'll put a line in their belly button, a central line, to be able to give them antibiotics and fluids. So if you can leave a little bit of the cord, that helps us be able to place that line. They're going to ask you about APGARs. I don't know you guys about APGARs at 1 in 5 minutes for babies. They can be anywhere from 0 to 10. You want to look at their heart rate, their color, their reflexes, their tone, and their respirations. So if their heart rate's good, if they're nice and pink, if they're breathing good, all those things, then usually most APGARs are usually 8 to 9. And usually their hands and feet are blue initially, and that is normal. We call that acrocyanosis. I've not seen very many babies come out that are completely pink, so a 10 is not usually something they get. Usually 8 and 9 is pretty reasonable. So there's the APGAR scoring thing you can see. We go by appearance, how they look, their color, pulse, as long as I get a good strong heart rate. You want your heart rate above 100. Grimaces, they're responding, they're moving from you, they're crying. Activity, they should draw up their limbs and be moving around. And then respiration is just that they have a strong, good cry. So if they're apneic or not doing any of those other things, then you guys would need a secondary intervention. So that's a good baby. They don't come out looking like that, but it's a good picture. So stabilization for the hospital, this is a big one. The last baby we had was a baby the mom said her last baby was born in the car actually outside the hospital. So this one was born in the toilet at home. Was not drugged, she just has her baby super fast. So the baby was born in the toilet, she tried to dry him off, but when they brought the baby in, he was naked, just had a diaper on, and was just in a blanket. What could they have done differently to help this baby stay warm?
Hat.
Do what?
Hat.
Hat, yep, that was good. Yeah, skin to skin. Yes, please. If you guys deliver a baby at home, put mom in her bra, keep baby naked and put him directly up against mom with a hat on and put a big blanket over the top of them. That is going to be the best temperature regulation because mom's going to be nice and warm and baby needs that. When babies get cold, they get stressed. They'll start grunting, retracting. They'll burn through their blood sugar. So we really want to try to keep them warm. But they did do a great job. They checked a blood sugar en route. It was 53, so that was really awesome. So they did a good job of thinking of that. But when the baby got to us, its sugar was less than 20, just because it had gotten so cold so quickly that it burned through all its reserves. So just always try to remember to do skin to skin with mom and baby if you can, and that'll really help the baby in the long term. They checked a blood sugar, that last one, and it was good, which was great. If mom would be willing to breastfeed, you can always let the baby try to nurse because those first few minutes, they're going to be the most awake and alert. So if they can try to eat and transfer and help keep their sugar up, that's great if mom will let you. Make sure she has no history of drugs though. Any kind of illegal drugs, or if you're concerned that she is, then we do not want them to breastfeed. So if there's any indication of that, just put baby skin to skin and go ahead and bring them in. We talked about putting the cotton balls or liner in the diaper if you think mom could have a drug history. I say do it no matter what, because you know what, some people are kind of tricky. They won't tell you that they've been on drugs, and if you put a diaper liner in there, we can figure out before they can tell us. And then put the placenta in a bag or container and bring it with you guys. So always remember your ABCs, airway, breathing, circulation. This last baby got blow-by, which was great. Just always remember oxygen's cold. So if they're already cold stressed, a little bit of oxygen is going to make them a little bit cooler. Breathing, just make sure they're breathing comfortably for you. Make sure they got good circulation. Like I talked about, their hands and feet are going to be blue. That's completely normal. Just make sure centrally that they're nice and pink. Try to prevent hypothermia, so place them skin to skin or try to wrap them in a warm blanket if mom won't let you do skin to skin. Try to keep their temperature between 97.8 and 99.5 and bring the placenta with mom and babe.
So Amy, I don't think any of the ambulances carry diapers. I'm just gonna tell you that. So
Oh, you don't?
no,
Okay.
normally they would just wrap them up with mom.
Really? Okay.
Or, yeah, so, and then it's also depending upon when if they're delivering the baby, we had to deliver them in the back. They probably let mom deliver the placenta here.
Here,
And
okay.
just, that's something I know that's happened in the past.
Okay,
But
awesome.
I truly appreciate. Anybody have any questions for him?
Thank you. Okay.
All right, guys, like I said, that's gonna be it for today. I wanna thank everybody for showing up and being online. Please, if you did not, make sure you put your name in the chat so I can add you to the online list that you were here. So guys, have a great day. Next month in July, we will be doing audit review here at Union Hospital on July 8th. It will not be down at regional, we'll be here next month, July 8th. Okay, thanks, guys, have a great day.